We're not live streaming, but we are recording this. Technical issues that prevents live streaming, so we will do it live after this as well. We have lots of new faces, but we'll get some people in different roles. So obviously we have Gail as our new Chief Officer. This is our first meeting, so congratulations, Gail, and welcome. And also we have Mary as our Chief Finance Officer for the first meeting as well, and Caroline as Interim Head of Information. So welcome all of you, and congratulations on the expected as well. So without further ado, we have any declarations of interest, either in general or on any items that we're going to discuss today. No, good. Minute of the meeting held on the 22nd of March. Now, I'm not going to go through every page because there's 18 of them, but I hopefully have read them all. And any amendments, anything that we need to change, we're happy to take that minute. Some nods. I think those minutes. In terms of the action log, there are only 2 live actions that were actually they are in progress. The first one relates to the intermediate care facility. That's remaining on this log until long-term plans for Falkirk care home discussed. We've got forward a future IGB. The community bed review progresses, and a report will be presented to a future meeting as well. And the second live action is about the dedicated dive within the board on budget pressures relating specifically to prescribing. That's already been looked at. There will be a further joint session to be organised after that. Okay, good. So moving swiftly on, we'll move to item 5, which is Gail's first report. Gail.
So, it's good to be here today. In my first Chief Officer report to the IGB. The Chief Officer report format is, as you will be familiar with from previous Chief Officer. So I'll quickly go through and give you some highlights from that report, and then I'm happy to answer any questions in relation to that. So we've got a number of recruitment updates that are highlighted, as the Chair has just mentioned. In addition to the ones that are noted in the report, other updates are that we have an interim locality manager that has been appointed. So that's Hazel Webb, who's currently our REACH coordinator. So she will be moving into that role as of Monday. Head of Primary Care has announced that she's been promoted to a different post elsewhere. So she's going to be leaving, and we're making an arrangement for the interim backfill of that post as well. And NHS Chief Executive has been appointed. You'll have seen in the media. So Ross McGuffey, who's currently the Chief Officer in North Lanarkshire, will be coming into Forth Valley in a few months' time. So we don't yet have the date for that, but that will be communicated when that's available. So in terms of us coming in as the new Chief Officer, I've set out a number of priorities. It's really important that we come within our financial resources. So myself and Marie and the senior leadership team are leading a piece of work to make sure that we're able to operate our services within the financial resources available, and to enable our reserves and non-recurring funding to be used for transformation and change, which we will need for the longer term. In addition to that, I'm looking at our leadership to make sure that it's fit for our current and future challenges. So that includes a review of the leadership structure, hence the interim arrangements we've got in place in a couple of senior posts at the moment to give us time to undertake that leadership structure review. In addition to that, we're looking at the leadership governance we have in place. So that's both at an executive and a non-executive level. So from a board perspective, we've got a development session in August where we'll be taking a look at our governance as a board perspective to make sure that it's fit for the job that we have to do going forward. And finally, my priority is around making sure that we're fixed as an organisation into the future, that we're able to provide sustainable community health and social care services in the next 5, 10 and 15 years forward. This will involve whole system engagement to design our future operating model in the context of our anticipated changing demands and the budgetary and workforce arrangements that we will be able to afford to take us forward. So there'll be updates on those priorities progressing in due course. The report also highlights a number of inspections that have taken place since the last IJB. So our housing support services across our 3 localities were inspected by the Care Inspectorate. We're really delighted with the outputs of that inspection. They were graded very good across all of the elements inspected. So that's a real credit to the ongoing work and the dedication of those teams. Our MEX service was also inspected in March and graded good, with the exception of people's health and wellbeing benefits, their care and support and staffing arrangements are right and staff work well together. Since that time, there's been a significant amount of improvement work underway, and there was recently a re-inspection. So we haven't had the finalised results of that yet, but the initial indicative response is the Care Inspectorate can see the improvements that have been undertaken. It's likely that the grades will be improved in relation to that. So we'll provide an update at the next IJB. The report also highlights the significant work that's been ongoing in relation to GP out of hours. So colleagues will recall that recently came into partnership as part of the ongoing integration last year. It was an area of performance that was being focused on as part of the NHS Forth Valley escalation, and there's been a huge amount of work that's improvement work that's been underway, including work led by the new out of hours manager who started at the end of last year. So he's been working with clinical and other staff in the team in the wider partnership. And at a recent meeting with Sir Lewis Ritchie in April, there was confirmation provided that we're demonstrating significant progress under new leadership. So we're really pleased with that progress. We're working on an initiative called Your Home First, and that's a whole system piece of work around the approach and the principle that being able to be cared for if the care is required in people's own home is best, and we want to avoid anybody going into acute hospital unless that's absolutely the right place for them to be recognised and the safest place to be is home unless acute care is needed. So that's a whole system piece of work, including both partnerships and NHS Forth Valley, and it's really about using the collaborative leadership approach that has been developed and continues to be nurtured across our system. There's a number of activities that are progressing in relation to that, including our integrated out of hours and streamlining access to services, the ambulatory frailty pathway, whole system discharge optimisation, and work with to look at the communities that have the highest levels in ED, again, to think about what supports can be put in place to help people be cared for at the right place in a homeless setting as much as possible. The Chief Officer report also gives a number of updates around publications as well, and I won't go into the detail of that, but I'm happy to answer any questions.
Thank you. You also asked to consider and comment on this report. If any questions, comments, observations?
There's been quite a lot of feedback from carers, so I'll try and keep it brief. But in terms of, you mentioned hospital discharge, there's when you're looking at that, your home first thing, will there be some consideration of discharge? What the carers are saying is that they're not being identified as carers, like when they're getting support in the hospital in particular, and they didn't know they could ask for a discharge plan, they're having to feel like they're out to fight to get support. They're actually not even aware of the support that's in the hospital. You know, the people from the carer centre that are there, there's 2 of them. I think before COVID, there was like leaflets and, you know, information available to carers, and I think one of the things we wondered was whether there could be more communication about that, maybe on the screens and waiting rooms and stuff like that, to let people know that they've got these rights in terms of the carers act. I know this doesn't sit specifically with what you're saying about this new service, but I'm just wondering if some of that could be taken into account for carers.
Chair, so absolutely. I mean, I think it's really important that we do recognise the vital role that carers play in our community, and it's absolutely right that we are able to identify and support carers at every step of the process. So I think that's really helpful in terms of highlighting that as an area for improvement. We've got Caroline sitting along here, and Caroline, I know, is taking an active approach in terms of making sure we're improving and our whole process around supporting people when they're coming in and coming out of hospital from a partnership perspective. Is there anything else you want to add, Caroline?
Yeah, one of the things that we're looking at is how how to divert communication and information to carers and to like patients and clients. So I'd be keen to have like involvement, you know, from carers around that to help like co-design that. So perhaps I think that'd be useful as an action.
Yeah, we have a carers voice meeting, every, I think it is this is where all the information I've got coming on now. It's really, they've really ramped it up. And they're always really keen for people to come in and talk to the carers at the carer voices meeting. So yeah, I think we would really welcome that sort of input.
Yeah, so I think that's something that look at how we can really make sure that we're designing a process that supports carers and clients and really that gives them information at the right time.
Yes, when it comes to a carer, you know, what information they're allowed to have and how they can best support the care for person if they don't actually have all the information.
I think we'll probably make sure that one of our leads comes along to hear more about the challenges that you're experiencing.
Thank you.
Margaret.
It's not in any way questioning the report and what's in place or coming in place. It's just a concern for the sort of residual cases whose relatives have been given choices which don't appear to be appropriate choices after discharge and have had stages of hopefully they were going to go to sheltered housing, but that was changed and it had to be a full-time care home place. And I don't know if there's any right of appeal if people feel that they've been forced into making a choice, but it's not the right choice for their relative.
That's like the assessment process that we undertake, and again, we pass on to Carolyn, because Carolyn's been doing a lot of work in looking at that assessment process.
Yeah, I mean, it's very difficult because I don't know the particulars of the case. So certainly like that maybe would be useful to know the kind of detail, like maybe like you could give me that and I could look at it. But in terms of looking at pathways for individuals, we always want to support someone in a homeless setting. So, but obviously based on assessed needs, and there's it's the assessment of that individual. We obviously take into consideration carers' views, but really our focus is on the individual that we're working and how we support that individual.
Good. And in the knowledge that this is all going to be better, it's just any kind of right of appeal. What should relatives do now if they feel the decision taken is not appropriate to their relative? Who do they contact?
I would expect that we would have discussion with I'm assuming there's a social worker involved.
Right.
So I would expect the first point of contact would be the social worker. If they're unhappy with the outcome of the assessment, then they'll speak to that team manager.
Right.
Yes, Hannah.
Thank you.
Thank you. Just think it's worth making a comment on the inspection reports. First of all, our thanks and commendation to the Housing Support Service for a very good inspection report. And I think it's important that the staff and managers there are recognised for that good work. In terms of the mobile emergency care service, obviously it's a little bit more concerning where there's the report was not quite so good. Credit goes to the managers who have taken action very, very speedily, given that the inspection was just in February. So I think it's good to hear. But I wonder if you could say a little more about how it came about and how it's going to be avoided in the future, that to keep up that improved standard.
In terms of mobile benefit service, we obviously have we put in a quick improvement plan that was focused around the recommendations that were within the care inspector report, and we recognised that we really had to improve our standards. And that's been reflected, I think, in the follow-up inspection that the inspector undertook, indicating that we have made significant improvement. Going forward, we've got an ongoing improvement plan, and we're very keen to develop the service so that it's more responsive, and it's clearer the information. There was an issue, I think, within that service that we weren't clear about the information we're given to the people that are using the service. So we've actually revamped leaflets. All that information is sent out to both clients, but also family members. And we've also put in kind of quality assurance systems around the service that they weren't as robust before, so that we're not waiting for an inspection to take action, that we kind of know the areas that we need to focus on. And that's on a few monthly basis that we'll be looking at that information and taking action.
Thank you very much. As I say, it was good that the action was taken so quickly.
David Heron online.
Thank you. Good morning, committee. I just thought it was worth maybe just commenting to highlight to the IJB. So discharge without delay is something that there hasn't been a great deal of consultation with GPs about this. We continue to get patients discharged from hospital without discharge letters and without medication, which obviously creates a problem for having people discharged without delay. You know, we'll be told by the health board that there's been a lot of progress on this, but it's not a noticeable progress from my end of things. The quality of discharge letters is not adequate a lot of the time for us to be able to care for people appropriately. Discharge without delay is a fantastic concept, but having people have operations and then be discharged into the community and expecting the district nursing service and the GP service to pick up all the complications, all the problems which would normally have been picked up by hospital teams, creates pressure on the primary care end of things. And I feel like we should be consulted heavily when these things are progressing. Consultant Connect as well, I see was noticed in the report. It was noted in the report there's been very minimal input from GPs in Consultant Connect, and I think the first we knew about it, the package had already been purchased before we were consulted on the appropriateness of it. So you know, I think it's important when we talk about integration, we need to integrate the views of primary care, general practice, district nursing teams when we make these decisions, and that is not happening to the degree that we would like to see it happen to. I don't think the solutions lie within the IJB, but I think it's important that we're aware of that situation. Thank you.
Just very quickly, I'm just a bit worried about some of the language in the report. So I want it to be as accessible by we all want it to be accessible by as broad a range of people as possible, stakeholders, and please just a reminder, please think about the English that we use, and so it is accessible by as broad a range. I know I've said this before, but I'll probably say it again. But please, plain English if possible. Thank you.
Yeah, item 8 on the report in terms of National Care Service talks about Scottish Government sending a package of amendments to Health and Sport Committee, and that package was published just the other day, I think Wednesday. It's about 300 pages long and written in civil service language that is very difficult to read, but it does seem to indicate some fairly fundamental changes in terms of the design of the National Care Service, and it talks about IGBs sort of becoming local care boards rather than being abolished. I haven't got through the kind of impenetrable language and being able to read the full suite of papers as yet, but it's something that we will need to think about. Obviously, it will feed into some of the governance discussions we're having. It will feed into some of the discussions about integration scheme, as we look to make sure that we're kind of future-proofing what we do now for this coming stream.
There's obviously been quite a lot of recent updates over the last week or so, so obviously these haven't made it into the report in terms of the timeline of the report. But we will, I think it's important that we bring that into the conversation about the IJB governance, and also we'll bring up other updates that things are changing. Well, there's been lots of recent correspondence that we need to really absorb to work out what that might mean for us into the future.
Any other questions, comments? Either on the report? But yeah, so we've got. I see that. Councillor Flynn online.
Yep, thank you, Chair. Thank you. I just wanted to follow up what David Hearn had mentioned regarding discharge, and really maybe without going into any personal details, just touch on discharges that come through, say, A&E or the Clinical Assessment Centre. So I'm not going to go into any personal details at all, but just really from what I've found and sensed, there's a couple of issues here. One of them is that as a patient, any patient, they don't really know once they've been discharged when the GP receives the discharge letter, or if they have received it. So there's a missing gap there somehow or other. It's not a lack of communication, it's a lack of knowing what's going on behind the scenes. The other thing is it's quite obvious that both in A&E and the CAC, the Critical Assessment Centre, they're hugely under pressure, hugely. And one of the dilemmas, I think, is that because of that pressure and staff changes, when the different shifts move in and move out, and it's handed over to another consultant, junior doctor or whatever, there isn't necessarily at times, for good reasons, the follow through that should be. Now, I spoke to, and I won't mention any names, to a secretary recently about a situation, and she said, well, this person is number 64 in the list to get a discharge letter sent out. I said, well, that's awful. She says, no, that's actually good. 64 is quite high up on the list. So clearly there's a pressure. Maybe there's not enough secretaries. Maybe secretaries, as I suspect, have been shared between consultants. But there definitely is a missing link here, which at the end of the day affects the very people that are the most important. And I'm sure David and everybody else will agree, i.e. the patient. Because sitting at home or wherever the patient is, wondering what's going on. I mean, in health, no news is not necessarily good news. If you don't hear anything, people want confirmation of what's going on, what the detail is, and what the follow-up is. So I just really wanted to put that into the mix, because it's easy to assume that everything runs smoothly, and of course in life it never does. But I do strongly suspect there's a need to either put extra resources into secretarial or take the pressure off. And I think a lot of the issues come when, how can I put it, shift changes within different departments, and I'm talking about A&E and clinical assessment, because they've got 30 minutes to change the shifts and all the rest of it. It's highly intensive, as you know, and stacked out there. So I just thought I'd make those comments, Chair. Thank you.
Thanks for that. And I see Frances has put her hand up, so she might. And she wants to respond to that from the health board's perspective.
Yeah, thanks very much. For those of you who don't know me, I'm Frances Dodd, Executive Nurse Director for NHS Forth Valley. The points that have been raised both by Dr Hearn and by Councillor Flynn, I will raise within the Health Board. I've already just sent a message to the Chief Executive and we'll discuss both of those issues. Thanks very much for your time.
Frances, thanks for that. Okay. Any other comments on Gail's report? We have been asked to consider and comment on it, which is what we've done, and we can then relate to item 6, which is the finance updates. Marie.
Thanks, Chair.
Good morning. It's good to be here. I was sat in last time, so it's good to be here now.
I suppose just before I start, it's just to set out that it is my intention to review the level of detail that's been provided in the budget monitoring reports. So I can hope to develop that over the coming months. And we hope to hopefully see some changes to these things like detail in the report, because I think it's fairly high level at the moment, and I think I'd like to bring a bit further detail and appendices for the board. So this paper is presenting the 24-25 month 1 information available at this time. It's customary practice to report an early position at month 1, but it's to be noted that no forecasts are available for services at this time. Therefore, the figures in the report are only in relation to the position at the end of April for the moment. The month 1 budget and actuals information is set out at table 1 at 4.1.
and shows an overspend of 199,000 is reported against integrated budgets and an overspend of 836,000 against the set-aside budget for large hospital services. 4.3 that sets out that large hospital set-aside budget, the overspend of 836 is assumed at this stage that the main areas of pressure across A&E, we have geriatric services, specialist mental health and general services, and that's in line with the pressure areas last financial year as well. This is offset in the report by an assumption that any set-aside overspend arising will be managed by NHS Both Valley as normal. Primary healthcare set at 4.5 is shown an overspend at month 1, £487,000. No allocation of reserves have been carried out prior to the report in this position at this point, and £3.5 million of use of reserves in this area has been agreed as part of the business case that was brought in March to balance the budget. It is expected that there will continue to be overspends in primary care, particularly in relation to the efficiencies required in prescribing budgets during the year and the known pressures within prescribing. But this will be monitored closely as the year progresses. For social care at 4.7, services are shown at breaking position at present. However, we are aware that there are significant demand pressures within care at home and within residential care. The March business case also approved a number of efficiencies for this financial year, some fairly challenging, which will need to be delivered. Works are underway to place a focus on the savings, and updates will be provided along with the budget monitoring reports to the next board. It's expected that underspends in staff and evidence last financial year are likely to continue during 24-25. At 4.10, community healthcare services are currently shown an underspend of 289,000 at month 1. As in the previous financial year, there are anticipated to be underspends across services in relation to vacancies and staff turnover. There are also recurring development funds within community healthcare, which are currently anticipated to have some level of underspend. Further analysis of the position with these funds will be included in the next report for month 3, and the underspend in these areas continues to be offset by pressures in GLS, the equipment store, and complex care. At section 5, it sets out the risks to the financial position set out. Partners in the IGB continue to face significant financial challenges with continuing pressures against existing budgets with limited additional funding. There are also challenging savings set for the year and required for future years as set out in the medium-term financial plan, which was agreed in March. £4 million of one-off reserves have been used, and funds have been utilised to help balance the budget in 24-25. And if recurring solutions are not found prior to the end of this financial year for these one-off items, this will become an additional pressure in 25-26 financial year, meaning that additional savings would be required over and above those already set out in the medium-term financial plan. At 5.5, it is noted that the full impact of the agenda for change, reduced working week, and protected learning time continues to be a risk for the IG financial position. The full impact still to be borne out. At present, there is no additional funding available for these elements of the agenda for change agreement. Another risk set out is that a 3% uplift has been included in the budgets for the council pay award. An initial pay offer has been rejected and negotiations will continue. Each additional 1% equates to approximately 370,000 additional pressure for IGB budgets, if not accompanied by additional funding. In summary, month 1 position shows an overall current overspend of 1.035 million against services, but does not reflect forecasts at this time. I expect there will be emerging pressures as set out in the risk section of the report when we receive the first forecast from month 3, which will be reported back to the board in September. And the board are being asked to note the challenges of the IGB budget set out in the report, note the year-to-date positions set out for month 1, note that some budget allocations are still to be carried out in relation to the integrated budget, to note that the forecasts are not available at this early stage in the year, and also to authorise the Chief Officer to issue revised directions to partners, setting out the updated budget positions at appendix. Happy to take any questions on that position.
Excellent. Any questions?
Just 5.5, they've changed the hours for the NHS staff. I know it's early days, but are we seeing that in practice that's becoming a cost at the moment as opposed to people actually being able to reduce hours in their roles?
We don't know yet. The forecasts aren't available, unfortunately, at this point in time. I know that anecdotally there is a notification that there are some hours being worked as overtime at the moment, that those reductions happen, but we won't see them until we get that for set forecasts, unfortunately.
Yeah, I take the point, obviously, that we shouldn't go too overboard on month one figures, but I mean, it is worrying that we're into overspends already in the year, but you know, with all the caveats around it. I think my main point is around the savings plan. You know, we know an awful lot of that was sitting at red in the risk register in terms of being, you know, kind of high risk to achieve. So just really a plea that we can look at that very closely as we go through over the next few months, so that we know exactly where we are against the forecast, how much we are saving. Because you know, if we're not making the savings that we need to make, then we need to look at doing something else fairly quickly. And obviously, the more into the year we are, the less scope there is for action.
So we actually have started to focus on the savings. It is a flash report that's going to be brought to senior management teams and extended senior management teams already. We've had a workshop already looking at savings, and especially the difficult to deliver ones and how we can action them. So there's an action plan in place to look at what the delivery might be, to monitor that through the year, and if there's any danger of not delivering the saving, to look at alternative options. So we are putting in place and focusing on that.
Thank you. And we'll get Robert Clark online.
Yeah, thanks, Chair. I just thought I'd give you a wee update on how we're getting on with the reduction in working week within NHS, if that'd be helpful. So we're working our way through them. They're obviously groups of staff that are quite easy. People who work Monday to Friday are quite easy, and they're implementing as we speak, so they're reducing, and most have reduced. The complicated rotas, such as 14-week rotas within labs and 12-week rotas within other areas, are proving a wee bit more problematic, so we're just having to work our way through them. So the stop deadline for total implementation, I believe, is November, with an interim report back in June or July to the government, but we are working through it. I can't say whether that's having a financial impact or not, but I just thought it'd be interesting or of note for the IGB to understand that we are working through the non-financial pay elements of the Agenda for Change pay settlement from last year. Thanks.
Thanks, Robert. Thank you. Any other comments, questions? Okay, so we were asked, as Marie pointed out, there were recommendations. They were asked to note the significant challenges to the IGB budget with pressures on set side, describing alongside new and emerging issues as outlined through the report. We also asked to note that the year-to-date budget overspend of 0.199 million reported against the budget overspend of 0.836 million against the set aside budget as of 30th of April. We asked to note that some budget allocations still to be processed, which will improve the year-to-date position on the integrated budget in the meantime. And we're asked to note the forecasts are not available at this early stage in the year, and we have to authorise the Chief Officer to issue the revised direction to Falkirk Council and NHS Sport Family ask for a direction summary and put out on Appendix 1. Are we happy to note? The next item is yours as well. Is the draft financial outcome, and this is for noting that.
This report sets out the final budget and unaudited spend information for services, and that final was spend of €2.606 million against integrated services at the 2023-24 year end. The set aside budget showed an overspend of €7.875 million at the year end, which was managed by NHS Sport Family. The overspend had been addressed by drawing from service pressures and general reserves. 2.659 million of draws were agreed by IGB at the meeting in March. The final adjustments against social care and health balances set out in the recommendations section. 2.3 notes that 808,000 of a final net underspend was added to the reserves in relation to services within health-related functions. And at 2.4, final draw of 755,000 was made for social care services. The final annual budget for services totaled 299 million, comprised of 256.775 million for integrated budgets and 42.952 million in respective set-aside budgets. Final adjustments and amendments to the budgets are set out at table 1, section 3.2 of the report. In March, an overspend of 1.924 million was anticipated against integrated budgets. Additional cost pressures of 682,000 arose further to that position, bringing the final unaudited overspend to 2.606 million as set out in table 2 at section 4.1. The additional pressures on these budgets since last reported related mainly to increased demand for care at home and residential care. There were also increased pressures on the set-aside budget, rising from 6.248 million, previously forecast, to a final 7.875 million reported, and the final overspend, as I mentioned, has been managed by the It's noted at 4.6 in the report. The large hospital services overspends were reported throughout services. The main pressures in relation to A&E, general, geriatric, and specialist mental health services. Challenges in these areas related to use of bank or agency staffing, linked to staff absence and vacancies, negotiating care, increased demand, and increased mix of students. Within primary health care, a final overspend of 1.1. In relation to prescribing pressures, we get with regard to the with high inflation and social care services have a quite overspend of 1.414 million. The main reason of the overspend to care and residential services demand, along with agency spend within these areas. There were offsetting underspends and staffing throughout services. Community health care was a final underspend of 1.1 million. This was due to recurring development funds underspends, plus vacancies and across community mental health, community-based AHPs, community learning disability. These were offset by continuing pressures in joint equipment store and in complex care. Table 2 at 5.2 shows the reserves opening balance for the year of 28.829 million and use of reserves of 2.829 used to balance the budget for 23-24 financial year. The 2.606 already mentioned to fund the overall overspend in year as set out in the previous sections of the report, and 2.133 million use of reserves used for the intended purpose. The overall use of reserves in 23-24 was 7.568 million, leaving a final balance of 21.261 million. Section 6 details the savings position for the year. 13.493 million were approved for the year as part of the business case. 9.7 million of those for integrated services and 3.7 for set-aside services. 7.855 million were achieved in the integrated budget savings, which was 81% of the savings set aside for those services, including the release of reserves of 2.81 million already mentioned. Set aside savings were not achieved during the year. The annual accounts were considered by the Audit Committee on the 18th of June for release to the external auditor by the statutory deadline of 30th of June. The board have been asked to note the draft outcome for 22-24. Note that the unaudited accounts have been considered by the Audit Committee on the 18th of June 24, and that the final transfers to and from reserves are set out at 2.3 and 2.4, and also to authorise the Chief Officer to issue the final directions in relation to 22-24 position as per Appendix 1. Any questions?
Any questions for me?
And in some ways, it's not actually a finance question, but around the underspend in community health services, which is quite substantial. I mean, obviously, in budget terms, pure budget terms, having a 4 million saving there is quite helpful. But I just wonder, in terms of the service then that is not available because of the vacant post, the lack of development spending, and given that this is the kind of community health provision that keeps people well and therefore out of hospital. You know, the obvious risk is that if we're making savings in community services, we're actually storing up problems an increased spend elsewhere. So I guess what I'm looking for is just a bit of assurance that that position is being looked at going forward, and we will be kind of, you know, looking to provide the services that we should be providing there.
Just to say, yeah, absolutely, some of that underspend. So there's underspend in relation to vacancies, but also in relation to development funds. So some of those funds are in relation to healthcare support worker funds, multidisciplinary team funds, and also the funds that were released from the ward closures from the community hospital. So just to reassure you that there are developments ongoing, some of that is now, so that where there were commitments last year, there was a part year effect for underspend. So some of those have been committed now. And I've been, so one of the areas that's been put into a fairly sizable sum has been put into the flow stream rehab at Cunningham House. So, and we are looking at other developments for those, using those funds as well. And it's about that transformation rather than putting it towards the overall position. We need to look at how we use those development funds for transformation.
Just to add to that, so, you know, absolutely. One of the things we're very focused on as a senior leadership team is that need to transform to make sure that we are sustainable into the future, that we're supporting that early intervention and prevention activity, so to help people stay well at home for as long as possible. So there is a lag in terms of developing a proposal and implementing it, and the slow stream meeting is a really good example of that. There's other pieces of work that we're working on, so I think as an IJB we should expect to see further reports coming forward with recommendations around transformational activity over the coming few months.
Councillor Flynn.
Yep, thank you, Chair. Just a couple of quick questions on 4.6, primary healthcare services. It mentions Buvidal, and obviously the fact it mentions it would tend to suggest it's quite a high value item. I just wondered if we know what the value of that is, i.e. what the amount is that's causing the overspend, and what was the reason that the Scottish Government no longer funded it? I might have missed that previously. Thank you.
So, sorry, Councillor Flynn, I don't have that figure in front of me. And from memory, I think it's approximately 400,000. But I'll let you know offline what that figure is.
Yeah, thank you.
Just to say, I'm not exactly sure, but I will confirm that for you. That's that. So the Scottish Government did fund Buvidal for the first year, but the intention was that it was always just a 1 year fund, and because the expectation was there, then there's that continuation of use of Buvidal, but the funding was actually withdrawn after that first year. I know in some areas the ADP budget is picking up some of that spend. It's actually going into prescribing and full for Falkirk.
Right, and is there any opportunity to, I don't know, feedback through whatever channels to the Scottish Government to ask them if they can continue it or whatever, you know, or is that a lost cause?
Well, I suppose in relation to how other funds are going at the moment, you know, we've seen Scottish Government looking to claw back funds that are underspent. And I know through the CFO's network, although I've only joined that recently, I know from my previous employment there have been discussions around Buvidal funding and these areas of funds where we're not getting confirmation of permanent funding or, you know, underspends are being clawed back. So I know CFO networks, and I'm sure Chief Officer networks will be picking up those issues as well. But I know Scottish Government do join those meetings, and we are appealing to them around all of these items. So we will continue to do that. Yeah, finances are challenging as well.
Okay, thank you very much. Thank you, Chair.
David.
Yeah, I always think the financial outturn is quite an interesting read, and what we can see again, unfortunately, is community healthcare services, both primary care services and community healthcare EHP services underspend, hospital services and prescribing massively overspent. This is where our money's going. This is where the increases are all going to. It's not the direction of travel we all thought we would see 10 years ago, is it? We all thought that we would see a shift in the balance of care, etc. It just isn't happening, and year on year we keep seeing this change. The agenda for change, reduction in hours from 37.5 eventually to 36, is not being done through efficiencies, so staff producing the same in less hours. It's being done by reduction, and unfortunately, again, community services are the ones that are the easy targets because they work daytime hours, so they've all had their hours reduced by half an hour. So within primary care, the health board employed people have all reduced their hours by half an hour. That's 110 hours of patient access lost. If we're reducing, I applaud Agenda for Change for getting a reduced working week, but the Scottish Government haven't given the funding to increase so that patients don't lose out, unfortunately. And patients are losing out in community access. Now, I understand in a hospital you need to staff a ward, and we have to spend extra money to keep the ward staffed. But within the community, if we don't increase the funding and provide the same amount of access to patients, then there is a knock-on effect on all the other services. Thank you.
Any more comments, questions, observations on that report? So as was pointed out, we've been asked to note the draft outcome for 23-24, note the unedited accounts for consider the audit committee on the 18th of June. And note the point 808 net underspending health and services between primary and community health care will be credited to the general reserve. Good use of the 0.75 million in the general reserve to fund the additional increase budget overspend within social care, and authorise the chief officer to issue revised directions to Falkirk Council and NHS for 23-24 as per directions that summary provided at appendix 1. Happy with that? Thank you very much. We'll move on to item 8, which Sarah is going to take us through. This is the proposed integration of children's and justice social work services with health and social care partnership.
Thank you, Chair, and good morning, everybody. So this report provides the board with an update on the National Care Service developments and an overview of the work that's been taken forward by the Integration Programme Board to consider whether children's and justice social work correctly sits within children's services within the council, or whether in due course these services should integrate into the health and social care partnership. So Falkirk Council considered a similar report at its meeting on Wednesday this week, and a number of decisions were taken based on the recommendations that were made, and those decisions largely reflect the decisions in front of the IGB today. Elected members noted that they were pleased to see an update report on the progress being made and welcomed future reports for update and decision. The background section of this report provides detail of the reason that this proposal is being considered. The council report at the end of last year recommended that work has progressed to enable a decision to be taken on the integration of children's services, social work and justice social work to the health and social care partnership by no later than April 2025. Importantly, it was recognised that over the course of this year, Falkirk's integration scheme is being reviewed, and that this presents a timely opportunity to consider and, subject to agreement, implement the transition of services to the health and social care partnership. So within this context, the council and the health and social care partnership have established an integration programme board. The board considers how children's social work services and justice are currently delivered and managed at a local level, and how in due course these services could be integrated into the HSCP. Stemming from the independent review of adult social care in 2021, the National Care Service Scotland Bill was introduced in Scottish Parliament on the 20th of June 2022. But the approach defined by ministers for the NCS goes significantly beyond the Feely review, which led to the independent review of adult social care recommendations, and there was a much broadened scope that was outlined, and we've included that in the report for you to be able to see at section 4. Notably, this includes consideration of inclusion or alignment of criminal justice social work and children's social work services within the National Care Service. So the bill overall sets out the principles of what it aims to establish within the new National Care Service for Scotland, and it will allow Scottish ministers to transfer a range of social care services and functions from local authorities to the National Care Service, subject to parliamentary approval. This could, again, I say, include children's and justice social work. There are 3 stages to a bill going through Scottish Parliament, and the National Care Service Scotland Bill is currently at stage 2. The timeline for the National Care Service currently is outlined at section 4.10. To consider the inclusion of children's social work in the National Care Service, the Centre for Excellence for Children's Care and Protection, known as CELSIS, was asked by the Scottish Government to carry out research and an evidence base for decision making. The study has 4 separate strands of work and they're noted at section 4.13. The concluding report was published in December 2023 and it brings together key themes and learning from across the study's findings and determines that there are a range of elements which contribute to creating the optimal conditions to improve support and outcomes for children, young people and families. The Integration Programme Board and subgroups are taking the Celsius report findings into consideration across our work. A similar evidence-based report is underway relating to justice social work, and once that's published, that's going to be of equal importance to our considerations. The Integration Programme Board is co-chaired by the IGB Chief Officer and the Chief Social Work Officer, and it's established to oversee a number of areas of work, and these are detailed for you at section 4.16. The Programme Board is supported by the following subgroups: governance, workforce, finance, communications and engagement. And today's report provides a summary of the work being undertaken by the 4 groups. The Programme Board has published an indicative timeline, and that is available for you to see via a link in the report at section 4.18. And that was developed mainly to ensure that the workforce can understand the proposal process. Some of the benefits of children's and justice social work integrating with the Health and Social Care Partnership are outlined at section 4.28, such as focused attention on transitions, pathways and thresholds between services, joint commissioning and pooled resources, and optimising conditions for staff to thrive. Some of the challenges of children's and justice social work integrating with the Health and Social Care Partnership are transformational change is complex, it takes a lot of time, workforce disruption and significant change of governance for both the Council and for the IGB. The Integration Programme Board has created a project initiation document, a PID, and that includes a section on emerging risks and issues that need to be considered by the Programme Board and the 4 subgroups, and this is kept under regular review at our meetings and it's updated. In April, the Programme Board began engagement activity with staff, stakeholder organisations and trade union colleagues to identify the opportunities and challenges facing the delivery of local social work services. 3 staff sessions were held in May and attended by a range of staff from across different service areas. Attendees were invited to give their feedback on the potential changes, benefits, challenges and risks, and lots of opportunity to ask questions about the proposal. Staff were given assurances that the proposal leads to no changes in terms and conditions or grades. Trade union representatives attended the sessions and have given feedback on the initial proposal. Engagement with the Integration Joint Board took place at the IGB development session in May. Feedback from the session has been collated to inform the development of the proposal, and engagement with the IGB will continue throughout the process. The insight gathered from all of that has informed considerations and the recommendations. Community consultation is planned to start in July and will run for 6 weeks. Just finally, the delegation of the children's and justice social work functions to the Integration Joint Board will require to be agreed by both the Council and NHS Forth Valley, as they are the parties to the integration scheme, following the consultation set out by the Public Bodies Joint Working Scotland Act. Thereafter, agreement of Scottish ministers is also required. Chair, I'd just like to take everybody back to the recommendations that are set out at section 2, and alongside other colleagues, happy to answer questions. Thank you very much.
Thanks for that very important but very complex bit of work as you've described to us there. Have we got any comments, questions or observations?
Yeah, I've said my view on the Unison's views, and I know that they're shared by Unite as well, that not surprisingly opposed to the integration, the moving of these services from the council to the IGB and the Health and Social Care Partnership. It seems an unnecessary restructuring, and one which the Celsius report, I don't know whether others have managed to read that, but Celsius report, in my understanding of it, is saying that there's no benefit to this overall benefit, so have a huge disruption to staff when they can do without it. We believe it's unnecessary and unhelpful and will distract staff's time from the day-to-day work to other work. So we're not supportive of this move.
Yeah, I came to the development day that when we spoke about this and found it really useful from a carer perspective. Unfortunately, carers want this, and it was something that they highlighted even before. Like, I think I raised it at the last meeting that they said they felt that they should be joined together and there would be more seamless transition for people, and that for them that was really important. That was brought together, so the carers welcome it being brought together.
Just to provide a wee bit of or offer of support for the community consultation, if there's anything that the third sector interface can do to help that process, then we're more than happy to help what we can.
So the recommendations and duly noting that those comments that have been made, the Education Unit Board were asked to note the position in relation to the proposed National Care Service, note the progress in the work undertaken to take forward the integration of the children's and justice social work within HSCP. Agree this work should continue to full engagement with staff and service users and a formal consultation on the addition of the children's and justice social work functions to the integration scheme. Agree that the proposal for engagement and consultation will be that the service transfers within their current structures largely as they are. Note there will be a report following consultation to Council and NHS Forth Valley Board asking to agree amendments to the integration scheme. And note there will be a further report to the IGB seeking formal agreement to transfer of children's and justice services coming from within the function of the IGB, subject to the outcome of the integration programme board work. Happy to note those recommendations. Move on to item 9 now, which is the Falkirk HSCP annual performance report for 23-24, and Leslie McCaffrey, who's online, is going to take us through this. Leslie.
Thank you very much, Chair. Good morning. The purpose of this report is to present members with Falkirk HSCP's annual performance report for 23-24. The Public Bodies Joint Work in Scotland Act 2014 specifies that integration authorities must publish an annual performance report no later than the end of July every year. The report must demonstrate evidence of performance in relation to the integration authority carrying out the functions for which it is responsible. The report should also reference core indicators in relation to performance against the national health and wellbeing outcomes, and we've also structured the report to show progress against the 4 priorities of the strategic plan. This is the 8th annual performance report, and it has been developed in conjunction with colleagues from across the partnership. As in previous years, performance information prepared by Public Health Scotland for 2023-24 will not be available until July. On this basis, we ask that the board consider the draft report and provide any comments, and delegate authority to the Chief Officer in conjunction with the Chair and Vice Chair to approve the final report for publication by the 31st of July. Thank you, and I'm happy to take any comments or questions.
Thanks, Leslie. Any comments, questions, observations on the report for Leslie? Not see any. So again, we're being asked to consider and comment on the draft annual performance report. We've been given the opportunity to do that, and delegate authority to the Chief Officer in conjunction with the Chair and Vice Chair to approve the final report for publication by the 31st of July this year. Happy with that? Okay, thank you, Leslie. So moving on to item 10, which is the Alcohol and Drug Partnership annual report. And Sarah, you're going to take us through this.
Yep, I am. Thanks, Chair. The Integration Joint Board is asked today to approve the Alcohol and Drug Partnership Annual Reporting Survey 23-24 for submission to Scottish Government. Each ADP is required to submit an annual reporting survey according to the template that's provided to us. Our survey response has been approved already by the ADP Executive Committee at its most recent meeting on the 5th of June. Once approved by the IGB, this survey will be published on the Health and Social Care Partnership web pages to comply with requirements on us to make the document available to the public. The survey is designed to collect information on a range of aspects relating to the delivery of the National Mission on Drugs during 23-24. The data will be analysed and findings will be published at an aggregate level as official statistics on the Scottish Government website. Falkirk's ADP survey response is attached to Appendix 1. We've provided detail in our response to questions such as the local and national structures that we have in place for monitoring and surveilling of drug deaths and harms, and how these are being used to inform local decision making in response to emerging threats. At question 7, which relates to local wellbeing initiatives for employees, we note that services routinely provide coaching, supervision and reflective practice groups for staff and volunteers which focus on wellbeing. Question 10 asks about the ways people with lived and living experience are able to participate in ADP decision making. We report that focus groups and conversation cafe events have taken place throughout the year to enable people with lived experience to contribute to the wider ADP agenda. The ADP structure has been redesigned and we're currently developing a lived experience panel for the Falkirk ADP executive. The existing barriers to implementing the medication assisted treatment standards and how we are overcoming these are outlined at question 29. Considerably more detailed updates on the good progress being made on the MAT standards is routinely reported to the Clinical and Care Governance Committee and periodically to the IGB. The last questions in the survey asks how children, families and communities affected by substance use are supported, and the final question asks us to confirm that our response is signed off by the IGB, and that, Chair, takes me back to today's recommendations, which can be found at section 2 of the cover report, and I'm happy to take any questions. Thank you.
Thanks. Any questions for Sarah on the Upland Partnership Annual Report survey? Gordon?
It's more a comment than a question. And all of the questions in the survey are very much about activity and inputs. And I know you can only answer in a survey the questions that you're asked, but just really to note that there is nothing at all there about impact. All of the activity sounds great, and there are some very good initiatives there. But we really need to know what the impact is of this work, and just really want reassurance that that is done separately from this survey.
Yeah, how keep you monitoring when it comes out stats, and you hope for that you're seeing that during
Yes, as well. Yeah, how are we monitoring the impact of the work that we do?
Thank you, Chair. So this, as has already been noted, is us responding to prescribed questions that have been put in front to us. There's much more detailed activity that sits around the ADP executive, which has recently been redesigned, and we have and holding it in a very different format than we had previously, where we have a number of senior officers who come together from across the partnership to make sure that we're scrutinising our performance across the piece. There's also various Forth Valley groups, again, coming together to very much focus on our performance. So we have to report into Scottish Government in terms of the progress that we're making, but the local scrutiny is considerable, and we do provide regular updates to various different governance groups over the course of the year. And I expect there'll be an update report coming to the IGB at some point in the future.
Thanks for that. Yeah, so we're basically been asked to, sorry.
That's okay, it's just a comment away from it. I keep talking about my family, my rights. I don't know if that fits into this, but just saying that once they knew about that, it was like night and day, made a massive difference. So I think we just wanted to highlight that and say we'd be good at that. Can we communicate it more?
So we're happy to approve the ADP Annual Report Survey 2024 for submission to the Scottish Government. So if we move on to item 11 now, which is the communication strategy and participation engagement report for 24-27. Leslie, back to you.
Thank you, Chair. The purpose of this report is to present the communication strategy and also participation engagement strategy for 2024 to 2027 and request approval from the board to publish. Integration authorities are required to publish a participation and engagement strategy that sets out how we intend to work with communities and community organisations. And this is in line with the Community Empowerment Scotland Act 2015. Communication has consistently been highlighted as a key factor in us being able to deliver against our strategic priorities. And on this basis, a communication strategy has also been developed. Both strategies are in line with the latest national guidance, Planning for People 2024, which is Health Improvement Scotland's quality framework for participation and engagement. And it's also been developed, the strategies have also been developed in line with the national standards for community engagement. The two strategies are provided as appendices to this report, and I'm going to very briefly hand over to Paul Surgeoner first, and then Jennifer Fakeney to provide a little more detail around about the individual strategies. Paul, thank you.
Thanks, Leslie. So the 3-year communication strategy has been refreshed using the UK government's OASIS framework for communication planning. So it sets out the partnership's objectives, audiences, strategies, implementation methods, and measurement metrics. So from that, we've identified 4 communication objectives, the first 3 of which were updated from the previous strategy. So these are to be a champion for Falkirk's local services and workforce, which is promoting the work of local services and our partner organisations, to build an understanding of the partnership services and how to access them, so promoting a range of signposting opportunities and promoting prevention and early support wherever possible. Also to deliver effective communications across the integrated workforce, so helping everyone who contributes to our services to feel part of the partnership, no matter which organisation or community group you're employed with or support. And lastly, the 4th objective, to celebrate diversity of our local communities in the workforce, so raising awareness and understanding of the different needs which can affect people's interactions with services. So we'll achieve these 4 communication objectives by setting and adhering to communication standards, improving our accessibility, championing inclusivity, and using a range of channels and methods. So to bring this to life, I'll quickly flag some of the 21 related actions within the Joint Action Plan. So a few of these are one is first to introduce inclusive format guidance to apply to the key partnership materials used by people who access support or services. We'll also look at improving how we communicate about the board and the decisions that the board makes, service developments and inspection results through the introduction of plain English, easy read summary of board topics. And we'll do our first one shortly after this meeting today. And then lastly, working to support the redevelopment of Falkirk Council's website is an opportunity to restructure the information that is currently spread about the health and social care services currently across the Partnership Council and other websites. So an opportunity there to really improve the signposting information that's available. So I'll hand over to Jen to cover participation.
Thanks, Paul. So as Leslie's kind of mentioned, the recently kind of published Planning for People guidance and the national standards for community engagement have both been used as a framework to develop this strategy, as it outlines best practice principles on how we can measure the quality of our engagement activities. And Healthcare Improvement Scotland's quality framework for community engagement and participation has been used to identify key outcomes and high-level actions so that we can aim to deliver high-quality community engagement that is consistent across the partnership and is aligned with national guidance. And some key areas of focus for the next 3 years is to increase our representation of people with lived experience. And to support this area of work, we've developed a participation agreement that sets out expectations for the participant and what support will be provided by getting involved with us. And we're also working with the Carer Centre to develop carer vet training in September and have identified opportunities for carers to get involved in strategic groups. And as part of the strategy, a community engagement toolkit will be available on the colleague hub so that staff have the tools and support that they need to plan and deliver engagement. And training will be provided to support staff to use this toolkit. And sitting alongside this these strategies will be a kind of joint action plan with the kind of comm strategy that will report our kind of progress quarterly to the IJB, and this ensures that we remain accountable and transparent about our engagement practices. And I'm happy to take any questions.
So that, Jen. Any questions, comments, or observations for Jen?
I just want to say that I think carers are really welcoming the involvement, and it's really up. So
my contact with members, users and members, that communication is actually, I've complained about communication years gone past, but actually I think there's some significant improvements in communication with frontline staff, which I do think it's important that I bring to the report, but also a caveat to that, there's still occasions when really important information doesn't seem to filter down, and on this occasion in these reports and the first that frontline staff hear about it is because I've read these reports and then feed it through to frontline staff. So I think most things generally have got a lot better. There's still time sort of important information about changes that really need to know about frontline worker. Still, there's holes in that system, so we need to check out. Thanks.
Thanks for that. Any other comments? Okay, so we're asked to approve the communication strategy for 24 to 27, approve the participation engagement strategy for 24 to 27, and approve the action plan outlining the implementation of both strategies. And we'll obviously consider the comments on the draft participation agreement. We're happy to approve. Okay. If we're making good time, but I propose a comfort break just now. So we'll go to 11 o'clock. We'll turn at 11 o'clock. Thank you. Folks, welcome back, and move on to agenda item 12, which is the Port Valley Mental Health and Wellbeing Strategic Plan, and Paul Smith's going to take us through this. Paul. Paul, yeah, we're just about to go into agenda item 12. You ready to report that?
Good morning. Yes, I'm ready to report. Thank you.
Thanks, Paul.
So thanks for considering the strategic plan proposal. I'll summarise the report. So by looking at point 3 first around the background, there's been lots of developments at national level, including the new Mental Health and Wellbeing Strategy 2023. There's a range of quality standards developed to support the strategy, and there's also the ongoing development of a learning disabilities, autism and neurodivergence bill. So Forth Valley's strategic priorities need to align with these and associated national outcome measures. The strategic plan will also help to improve the coordination of delivering mental health and wellbeing services across the 3 local authorities, all recognise it with their own unique challenges and priorities. So moving to point 4 around the approach, the strategic plan, we intend to take a life course approach from child and adolescent to adult and older adults, including dementia. And it will also consider our forensic population and people with comorbid substance use issues. The intent will be to highlight learning disabilities within the plan, but with a commitment to develop a specific plan for learning disabilities with a broader scope beyond mental health. We intend to take a structured approach to developing the plan using Healthcare Improvement Scotland's good practice framework for strategic planning, and working together with people and families with lived experience across Forth Valley, our community planning partners, and with support from public health. And through the establishment of a strategic planning group, we aim to develop the plan taking the following steps, and I'll summarise what's in our approach. So phase 1 is our analysis phase. So we will be reviewing a whole range of information and data intelligence, including the views of people with lived experience, and scope out existing service provision to define a set of high-level priorities for consideration by the end of September 24. There'll be engagement with wider stakeholders to gain consensus on the priorities, and that should conclude by the end of November, with a high-level draft plan developed for consultation by the end of the year. The final version should be ready for approval by the IGBs by end of the financial year. Local strategic commissioning processes should support the development and implementation of the strategic plan as well, where appropriate. So lastly, in point 5, in the conclusion, through all the points said earlier, we need a strategic plan to align our priorities and to be able to report against the national outcomes framework within the mental health and wellbeing delivery plan. We don't anticipate any additional resource needed, instead delivering the project through the coordination of strategic planning resources from across all partners. I suppose the indirect resource implications will take the form of releasing staff time to commit to the range of engagement and consultation requirements as outlined in the direction. Thanks. I'll leave it open for questions there for myself and Jennifer.
Thanks, Bob. Yes, we'll also be joined by Jennifer. So welcome, Jennifer.
Thank you.
Any comments, questions, observations on that? Yes.
Thank you, Chair. Yes, Paul, Jennifer. The report refers to primary care, to early intervention, prevention, life course, but in scope, most of the services seem to be what I would regard as secondary care services. There's a bit missing for me in terms of primary care, schools, third sector, who all take quite a significant part in this work for mental health and wellbeing. I wonder if that's something that's not in scope for a reason, or something that's potentially could be considered.
No, I think that is all in scope. Apologies, I'm sorry, because you're on the screen, I'm not sure who's speaking, but I think it's somebody in the room, isn't it?
Sorry.
Hello. So no, it absolutely is in scope, and the purpose of this really is to try and develop a life course end-to-end mental health and wellbeing strategy, and we're absolutely aware that has to be beyond secondary care mental health services and has to involve all our partners, including those areas. We spent some time debating and discussing whether it should include children, which then obviously gets into schools and things as well, but the feeling from Children's Services who we spoke to was very, very keen that we do include that. So I think we would do that, and we'd be looking to have on our steering group representation from Children's Services as well, to ensure that we include those aspects, also from primary care as well, to make sure that we do include those areas. So yeah, so perhaps that's not clear enough in our paper, but it definitely is part of our overall scope.
I think obviously it refers to carers and the carer rep. So it refers to carers in there. And obviously a lot of the things that are happening or that are maybe not happening, we spoke about earlier, like discharges. We spoke before about self-directed support, which I know is under review. And another thing that's come up through carers is just the level of assessment that is required for it. So all of these things and having to fight and everything are having a great impact on mental health of carers. But on the other hand, there's some positives. There are some things that they've raised, like the support that Strathclyde Hospice gives. Again, all of these things are just helping the mental health of carers to be better. And then there's been huge feedback around about the new social care officer that's in place. I think I sent you some feedback on that, but a number of carers are really talking incredibly positively about this new person. I think it's only one posting at that pilot, and they're hoping it'll get, we'll have more people doing that. Again, that level of support that's coming super fast for carers is really having a much more positive impact on their mental health. So I think some of this might come out in the conversations that you're going to have with carers. And just the last thing is just making sure that when we're looking at these things just across the board, that when there's consultations and things happening, that people are getting the feedback, that they know what's happening. It's not just like tumbleweed. There's been quite a few comments from carers just generally about things, consultations, things that are happening. So thank you for you.
I think that's a really good point, actually, and we do need to absolutely make totally sure that we include carers and the voices of carers in this. So we will take a note and make sure that we do that. Thank you.
Yeah, I think this is a good report, a good plan for the plan, if you like. I think the 2 points I would make is that the level of consultation is high, which is great to see. And also just to follow up from Ian's point, it very much has to be a plan for better mental health, not a plan for mental health services. And I think that's probably implicit rather than explicit in the report.
I think what we're keen to do is we try and get it across the whole breadth of that. So we absolutely include the plan for improving mental health at population level, and also looking at how we ensure that people who do require access to the specialist tier of mental health services have that as well. So I think we're keen that we get across the whole span, I think.
Any other comments, questions? Margot?
Just the need to have service users at the levels which are appropriate, because I think their voice is actually really, really important, and too often they have been, because of the article, difficult sometimes. It's been difficult to involve them, but they must be.
Yeah, I absolutely agree with that, and you're absolutely right. We've tried from a secondary care mental health service point of view. We have made repeated attempts to try and engage the voice of service users, and we have found that very difficult, being honest. And unfortunately, one of the challenges is the stigma that people feel. And when we ask people, they'll say, yes, I'll speak to you on a one-to-one basis, but I don't want to be involved publicly in anything where I'm identified as a user of mental health services, and that has been a challenge. I think Paul's already got some thoughts about how we make use of resources and groups that are out there already in the community, and that we try and tap into that to make sure that we do put the voice of service users absolutely at the centre of this work. Yeah.
The voice is so powerful when it's heard.
Yeah, I agree.
Find that you're looking at evidence for things. I do appreciate how difficult it is to do so appropriately. Maybe case studies or something.
Absolutely, yeah.
Involve people individually that way without them having to be standing members of any committee or anything.
Yeah. Yeah, thank you.
Thank you. Thank you for the book. Just wanted to comment that it's also, I would like to see it a bit more, again, in terms of the preventative approach, in terms of using, you mentioned using, linking in with community groups. I mean, community groups, sports centres, that you can have local activities that can be fundamental in terms of the prevention of the deterioration of mental health. And it is really, really important, actually linking in with whether it's community centres, coffee mornings, etc. I think all of that has to be factored in because it does have a very big impact.
Yeah, absolutely, absolutely.
So, any other comments, questions, observations? So we are being asked to approve the plan for the plan, as Gordon puts it, so happy to do that. Then I also need to instruct the Chief Officer to issue direction to the Council and the NHS in relation to this as appendix 1. I'll be happy to do that as well. Yeah. Thanks, Paul. Thanks, Jennifer.
Thank you very much.
Thanks very much. Thank you.
Now we go into item 13, which Callum's going to lead us through, which is the performance monitoring report. Callum.
Thank you, Chair, and good morning, everyone. For this iteration of the performance monitoring report, we've also provided a briefing of the Improvement Services Local Government Benchmarking Framework, and I'll provide some further detail on that towards the end of my update this morning. In terms of our regular report, performance is reported up to June 24 where possible and with a year-on-year comparison. As before, there's a focus on exception reporting, and I'm now just going to go through some of the key areas highlighted in the exception reports. There are continued pressures around emergency department 4-hour compliance and around delayed discharge. The report details the March 24 position, and of course the overall position remains under continual review, and sections 3.1 and 3.2, which start at page 264 of the packs, provide further details as well as some of the actions ongoing to support these areas. The report details for both Falkirk Council and NHS services the number of complaints received and the percentage responded to within timescales, and highlights a decrease in the percentage of complaints responded to within timescales, as well as an increase in the volume of complaints received for NHS services within the partnership when we compare the year 23-24 to 22-23. The Clinical Care Governance Committee continues to oversee complaints performance, as well as monitoring the underlying themes. There's detailed exception reports for sickness absence across both Falkirk Council and NHS services attached to the partnership. For Falkirk Council, absence for the year 23-24 was 9.7%, which is a reduction from the year before when the figure was 11.1%. For NHS services, the overall March 24 sickness absence position is reported as 7.82% compared with 8.33 in June 23, sorry. Reduction in absence across both Falkirk Council and NHS services is of course encouraging, but figures do remain in excess of the long-term targets that exist for absence management. The report details the latest position for waiting times for psychological therapies, and in March 24, 73.6% of patients started treatment within 18 weeks of referral. That's an increase from the previous month position of 69.8%, however, a decrease from 78.5% in March 23. Lastly, in terms of the exception reports, there is a report for drug and alcohol waiting times, which is an indicator that has previously had high performance. However, performance against the access target decreased significantly for Q3. The main challenges identified were around staff vacancies and high levels of staff absence. The vacancy situation is now largely resolved, which has contributed to improved performance within the waiting times in more recent months, and we hope to see that reflected in the data for the next iteration of our performance report, but we will of course continue to monitor that closely. There are a couple other indicators that I'd like to just highlight quickly that were not part of the exception reports. So firstly, indicator 72A, which is on individuals waiting to receive a care at home package. We first highlighted about a year ago that significant progress had been made in reducing the waiting list, and it's pleasing to see that improvement has been not only sustained, but it continues to reduce as well. And secondly, indicators 32 to 35, which are about anticipatory care planning, show a large reduction in the numbers. We've been looking at that closely alongside NHS Forth Valley and NHS National Services Scotland, and as they hold the data, and we're having discussions about this as they believe that there's a national-wide issue with the data, and we hope to provide a more detailed update around that at the next meeting. Appendix 3, which is on page 286 of the pack, contains a briefing from the publication of the Local Government Benchmarking Framework, which was released just earlier this year. It covers some indicators we're familiar with, and for a time period that's maybe further in the past. However, it's a very helpful tool and adds value in that it allows us to look outwards and compare ourselves to both the national picture and to our peer groups. In order to support interpretation of the publication, we've produced a briefing which details each indicator as well as a performance at a glance summary. The summary focuses on how we compare with the national average, and we've produced 3 categories, which are performs better than the national average, which is defined as greater than 2 percentage points better. There's a category called similar to Scotland average, which we've said is within a range of 2 percentage points, and the third category is does not compare as well to the Scotland average, and that's when something would be below 2%, 2 percentage points. There are 11 indicators relating to health and social care, but at the time of writing, 4 of those indicators are not available as they come from the Health and Care Experience Survey, which has just been released. However, we will pick up these 4 indicators as part of the core suite of integration indicators, which we intend to bring to the September meeting. So from the 7 indicators that were updated, 2 indicators fell into the category of better than the national average, and that included indicators on care inspectorate grades and those with long-term care needs receiving care at home. And the 5 indicators that were in the category of being out with the national average included there was 2 indicators on costs, self-directed support, and some of the secondary care indicators as well. So hopefully the local government benchmarking framework briefing has been useful, and we're also sharing it internally as well to try and encourage and explore learning opportunities. In terms of recommendations, the board is asked to consider and comment on the content of the report and to note that appropriate actions continue to be taken to address the issues identified. Thank you for listening, and I'd be delighted to take any questions or comments you might have. Thank you.
Thanks, Callum. Lots of information there. Any questions, or observations for Callum? Robin.
Yeah, I was looking at the benchmarking data, and I take the point it's 22, 23, so a little out of date. But one thing that did stand out for me was the rate of admissions, where we're about 40% over the Scotland average. And it's a position that I don't quite understand, where we have high levels of delayed discharge, but also high levels of people who it looks like are being discharged too early. I just wondered if there is kind of more up-to-date data on that, or as mentioned, if we use that in the best we have.
There is, thank you for the question. So many of these indicators are actually also covered in our regular report. So you mentioned readmissions and delayed discharge there. So we obviously do monitor that as part of our ongoing performance monitoring report. But I suppose what the value that is brought here is that comparison to the national picture, and as you rightly point out, that performance doesn't compare well for these indicators. Just to highlight the point about the readmissions one, I don't know if people remember, but there was a report brought to IGB about I think it must have been about 2 years ago, possibly 18 months to 2 years ago, that focused on readmissions. And one of the things that it highlighted there was that there was a change locally in how we calculate readmissions locally. And there was that change inflated our readmission rate. Now, our readmission rate actually, I think, was already above the national average, but that change had put a bigger gap. But I suppose what is pleasing to see that while we are above that national average for readmissions, the trend does show that it is it hit a high a couple of years ago, and it maybe is starting to slowly come down. But obviously we'll continue to monitor that closely.
Yeah, thanks, Carol. That does ring a vague bell, and I can hardly remember the quotes I read yesterday, let alone 2 years ago. But certainly the figures for 23 and 24 are about a third of what the figure was for 22. So either there has been a remarkable improvement, or there is a recalculation in some way. Whatever it seems as though we are heading in the right direction. It's great to see.
David?
Yeah, on the readmission rate, I recall Andrew Murray bringing a paper around that, and at the time I think the comment was, well, we're just shuffling around the data here to make it look better. We're not actually doing something tangible about stopping and reducing our readmission rate. And unfortunately that's maybe showing in the statistics, because although we got them down because we recalculated how we presented it, they haven't really significantly dropped since then. Again, I just come back to the point, if we don't send people out of hospital prepared to manage at home with a proper discharge letter and with medication and with the right care package, then they are going to be readmitted. And we really, I really think we need to make better progress on this, because I think we're still quite far above the national average.
Yeah, so do you think Gail wants to come back there?
Yeah, not in relation to that area of focus, but in terms of the benchmarking data is really helpful for us. Obviously, in terms of our comparison, we're not comparing really well in terms of the number of indicators, but it does allow us to focus on some areas that we can focus our improvement on, including the one that was just being discussed, but also some of the financial indicators in terms of where it's showing that we may be spending more than some other areas in terms of given our financial challenge. That might help us focus in terms of potential efficiencies and things that we could make, which will bring us more into line. In terms of asking the question, why are we spending more than other our benchmark comparators?
Yeah, I mean, I do.
Sorry.
No, I think benchmarking is good. I think that the element is that the information has got to be as up to date as possible. And actually, I look at the family group that we're in, and I see some very significant differences in terms of where we're benchmarking the Fisher Valley, for instance, they identify the Falkirk. But I think it is useful, but the devil's in the detail. You know, what is behind the late discharge? Why are costs slightly higher? But you're right, as Chief Officer gives you I suppose the movement to start to dig into some of those stats. Kirsten, how do you want to take a comment?
Thank you. Interested in, again, I like the benchmarking to get an idea of where we sit and others. And the one that rather jumps out at me is the home care cost per hour. And that's obviously a matter of concern, and I see from the text that this indicator should be interpreted with caution. I wonder if we could say a bit more about that, and are we doing something to address that issue? Because it does appear that our costs are significantly higher than the average, and the range of costs is huge. So it does appear that there needs to be some serious work done to look at that comparison and ensure the comparison is like for like, for starters, and to make it meaningful. Because as it stands at the moment, it doesn't look all that meaningful as a comparison.
Yeah, I think you make some really excellent points there in terms of that range there. It absolutely does suggest that we can't be comparing like for like in all of those examples, because the range that is seen is far too great for it to be realistic. I think we are feeding that back to the improvement service, in that there maybe needs to be another look at the definitions, because it does suggest that different areas are interpreting the definitions in different ways. So we are feeding that back. However, it might be that we could strip out the ones that are either extreme, either higher or lower, and we start to see where we are within a more reasonable range. So I think there is learning to be had there, but I think we are right to be cautious with our approach and the interpretation for some of it.
Well, do you want me?
I suppose it's just to be somebody in the field says very clear we're not comparing like for like care, particularly in terms of the home care costs. Historically, some local authority areas reported the hourly they pay their home carers, whilst others submit the total cost of the service. It would include management costs, add-on costs, a whole range of additional costs. So that was, I guess, a real difficulty to get a real comparison around that. But I guess just picking up the point about, I guess, improved efficiency. Members will recall we brought forward a new model for our care at home service, which actually we're pressing towards implementing. Part of that was actually to make the in-house services efficient, so also brandly. But I guess that for me it is that although the benchmarking information is really helpful, it allows us to focus in on areas and ask the questions quite often. So it's just a hard work.
It does need a bit of a deep dive, I think. And it could be entirely legitimate for our cost to be higher if we've got a much better service, for example. It's about the quality of the service versus the price.
Yeah, so I'll just add to what Martin was saying. I was involved in a group who were reviewing the gathering of this type of information a few years back, and there's one thing to point out is some places don't have an in-house service, so that will automatically make our cost a bit higher. And definitely a lot of people are gathering that data in different ways, and it's very difficult to prescribe that everybody does it in the same way because of the different complexity in different areas. But absolutely, it does merit a deep dive. But as Martin says, we're looking at the redesign scope. Thank you.
Hello. Just to say, it's a comment. This is incredibly complex, as has been so much of the agenda this morning, and there are several strands in the decisions that are made. And on behalf of service users, I just feel with delayed discharge, time is of the essence, because sometimes by the time things are put in place, they've moved on to another stage and another destination. And I'm thinking of a lady I know who almost came into hospital, was going to go to sheltered housing, but by the time she was discharged, she had to go to a care home, and that disturbs me. That I don't know if we can perhaps develop the relationship between the people delivering the care.
Just to come back on that, so I think that's a really important point to raise, that actually when people are in hospital for longer than need to be, the deconditioning that can happen can result in a greater level of care that's required when they are able to go home or to a homely setting. So we are working whole system with our colleagues in the acute hospital and across partnerships to work on constantly how can we support early intervention and prevention, how can we where appropriate, provide services in the communities so people don't need to go into hospital, and when they do need to go into hospital, making sure that they're able to be supported to come out as quickly as possible. As you pointed out, it's incredibly complex and there's a whole range of different factors that impact on that. But as well as looking at the delayed discharges as an indicator, we're also looking at key factors that take place at the front door and before people get to the front door of hospital to again help people stay safe at home for as long as possible, recognising that deconditioning every day that somebody's in hospital, they don't need to do that deconditioning increases or makes it hard for them to come home. So we absolutely need to continue to focus on that. We do have a really strong whole system focus with collaboratively around the whole hospital flow and the discharges as well.
Any other comments, questions, observations? No, reports.
Martin, yes, just a comment about the issues around the truck and firms. Callum highlighted the volumes and shock at 50%. That issue was picked up by the EDP towards the end of last year. Yesterday highlighted that we're up to 96% now. So it's just to give for some issues that actually good action to resolve that issue.
Good, thank you. All right, so no comments, questions? No. Thanks for that, Callum. So we were basically asked, consider commenting the content of the performance management report which we've done, and note that appropriate management actions continue to be taken to address the issues identified through these performance monitoring reports. Excellent, thanks, Callum. So we'll move on to the next item, which is item 14, which is HSCP communications update. And Paul is going to come on. Paul.
Thank you very much, and hello again. So I'm here to present the quarterly communications update, which provides a summary of activity from across the services and demonstrates how we are implementing the partnership's communication strategy. So to begin with, the report provides a summary of media coverage between January and March. This includes 6 pieces of media, quite a quieter period this time, with over 57,000 opportunities to see across Falkirk Herald and Daily Record. On our social media channels, we achieved a reach of over 20,000 and 230 shares online. And on the Care Opinion feedback platform, we received news stories. So the report provides an update of key pieces which support services and developments across the partnership. And within the last period, these include Adult Support and Protection Day in February, where we issued a localised media release reminding people of the signs of harm. The theme of this year's national campaign was sextortion, which is the use of sexual images or information for blackmail. And alongside that media release and activity, the ASP committee ran a 2-week Facebook advertisement campaign outlining the signs of physical, sexual sexual and emotional harm and financial harm as well. Elsewhere, Thornton Gardens received an editorial feature in the Falkirk Herald of the Short Break service that outlined the recent transformation and included an interview with Thornton's manager Sharon and photography from the newly decorated themed bedrooms and communal areas. We've also received media coverage from the discussion of the last IJB meeting, which covered comments and well wishes following the retirement of our previous chief officer. And at the end of the document is a complete list of articles and headlines with online links, if available, if you'd like to review that. Over on the website, we published a new service page for self-directed support, which supported the more recent SDS Month of Action, which has helped to raise understanding of the 4 options and provide staff with new materials and leaflets for improved signposting to either of the options or for further support and advocacy from ILA Force Valley. In terms of upcoming activity as detailed in the report, we've got quite a busy consultation period ahead, covering much of what's been discussed today. So that's the integration of children's social work and justice services, and then the development of several new strategies covering alcohol and drug services, learning disability, mental health, dementia, and home first. And I think last IJB meeting, I noted that we are awaiting a refreshed Living Well Falkirk platform, and we'd expected that in May or June, but I think we're still waiting that, and it'll come later this summer. And then lastly, I'll just return to the recommendations of the update, which are to consider and comment on the content of the report, and to note that from the next IJB, this recurring agenda item will become the communication and engagement update, which reflects the joint action plan and strategies that were presented earlier today. So I'll hand back to you, Chair, and welcome any comments.
Any quick questions, comments, observations on that report? No? Okay, off later there, Paul. That's happy to accept your recommendations. Thank you very much. Move on to the final item, which is just approved minutes of meetings, just for noting the committee 1st of March, Nicholas Care Governance Committee on the 26th of January this year, and joint staff forum from February of last year, April of this year, and street planning week of February of this year. There'll be as a variety of chairs and members of the committees in this meeting. So if anyone's got any comments, questions, observations, any of them, then you start to say it. Okay, thank you very much for your efforts today, folks, all the presenters, and for those attending. It's the conclusion of the meeting.